The next speaker is Jim Kofler from Mayo Clinic, Rochester, who is going to be speaking on scan acquisition settings, trade-offs between speed, resolution, and dose. Jim.
Well, thank you. It's an honor to be here, and I hope you find this information useful. I'm going to be talking about some trade-offs between scan acquisition settings, particularly between scanning speed, spatial resolution, and radiation dose. And what I'm going to cover first are some clinical considerations. We're going to go through these pretty briefly because these are going to be covered in more detail in some of the other sessions. And then we'll look at some of the technical considerations and some of the trade-offs and things that we have to deal with on a day-to-day basis. Okay, the first clinical consideration is scan time. Ideally, we'd like to keep the scan time within a single breath hold, which typically tends to be about 15 seconds or less. Okay, another advantage to having a very quick scan time is that we are less susceptible to patient motion artifacts. And this is especially important with pediatric patients, where the kids tend to squirm around a lot, and in the emergency room, where the patients might not be able to sit still for very long. Another clinical consideration is what do we need to visualize? What do we need to see? Are we looking at very fine detail with high contrast, where we are particularly interested in our high contrast spatial resolution? Or are we looking at organ boundaries and structures, where we want very low noise and very good low contrast resolution? And finally, dose is also a very important clinical consideration, and we hear a lot about the doses being too high. But equally as important is that the doses aren't too low. If the noise is too high, the image quality isn't acceptable, and the scan has to be repeated, we haven't saved ourselves anything. Okay, so what we would like to do is match the dose to the clinical task and to the patient's size, and you'll hear this repeated throughout this entire summit. Okay, on to the technical considerations. The first parameter I want to talk about is the rotation time, and this is the time it takes the tube to make one rotation within the gantry. It obviously will be proportional to affecting the total scan time. If your scan rotation time is shorter, your total scan time will be quicker. It affects how many photons can be thrown into any given slice during one rotation, so it will affect the noise and the low contrast resolution, and of course it will also affect the dose. Generally, we want to keep the rotation time as quick as possible. However, a few things you should be aware of. If you do make changes to your total scan time, you will have to check your IV contrast timing. You don't want to outrun your contrast. Additionally, if you try to compensate for a reduced rotation time by increasing your MA, you may be at or near your tube or generator limits, which can be problematic, and I'll talk about that a little bit more as well. The next thing is the tube current, which is the current delivered to the X-ray tube. It's directly proportional to the number of photons that are produced. Therefore, it will affect the image noise and your low contrast resolution, and it will be proportional to, your dose will be proportional to that setting. If you double your MA, you'll double your dose. Something to watch out for is if your MA is, again, near or at the tube or generator limits, you can run into problems, especially when you're using dose modulation. If you have things set such that the MA you used is perfect for a standard size patient, but it's at or near the generator limit, and then you get a slightly larger size patient on the table, the scanner is going to ask for more than it can be delivered, and you're going to get a warning thrown up on your console, and you're not going to be able to proceed. And next I want to talk about pitch, and pitch is the amount of overlap or spacing between the slices during the acquisition. If you think of the acquisition path as being a spiral or a helical, I think of it as like a slinky. If you pull that apart more, you're going to have a much quicker, faster total scan time. If you compress it and have more overlap in your slices, it's going to take you longer to get through the scan. It also will affect how many photons can be thrown into any given slice, whether or not that slinky is pulled apart or compressed together. So it will affect your noise and your low contrast resolution, as well as your dose. A few things to be aware of here. Pitches that are greater than 1, may show a slight increase in slice thickness. Okay, and the scanner won't necessarily tell you that your slices are thicker than you think. But if you went and measured them, you would see that it's actually has increased the slice thickness on you with these greater pitches. And this is vendor specific. Also, pitches that are greater than 1 may, again, require that the MA be increased near the tube or generator limits. Okay, I want to step through an example here, and this is the low contrast resolution section of the ACR Phantom. And I just want to show you what happens to pitch, what happens to dose as we change the pitch, what happens to image quality, what happens to the noise. Okay, what we're looking at here on this Phantom, in the center is a 25 millimeter rod. Then over on the left we have a set of 4 6 millimeter rods, a set of 4 5 millimeter rods, some 4 millimeter rods, 3 millimeter rods, and there's also a set of 2 millimeter rods that we don't need to be concerned with. Okay, so we are starting out here at a very low pitch, and we have a CTDI volume of 162 milligray, which is just kind of relative what I set up for this Phantom scan. And what I'd like you to do before I start clicking through these and showing you different pitches is to, if you can, pick the lowest set of rods, the smallest set of rods that you can visualize now. Okay, and it's probably around the 4 millimeter rods, which is about at the 5 o'clock position on this image. You might be able to convince yourself that you can see a few of the 3 millimeter rods. Okay, this is at a pitch of 0.5 and a CTDI of 162. As we increase the pitch to 0.938, you see that the detectability of those rods isn't quite as good as it was. There is an increase in noise, which is kind of subtle as we can click through these much more rapidly, but the low contrast visualization isn't nearly as good when we increase the pitch. However, note that our CTDI has gone down from 162 to 97. As we increase the pitch to 1.375, again, now you're lucky to see really any of the 4 millimeter rods. Your low contrast detectability has degraded. The noise is much more apparent, but the dose is much lower. The dose is at 66. And finally, when we go to a pitch of 1.75, clearly there is a significant increase in noise. The low contrast detectability is not nearly as good as it was with the slower pitch, with the smaller pitch, but the dose is less than a third of what it was before. Okay, so as we increase the pitch, as we pull our scan apart, we do get lower dose, we get faster scanning speed, shorter scan times, but we take a hit, and a pretty significant hit, with our low contrast resolution and our image noise. Okay, I want to show you an example of the interaction of these 3 really basic parameters. And what I'm showing on the right here is a table of the maximum allowable effective mass for this specific scanner. Now, effective mass is just the mass divided by the pitch, so it kind of considers all 3 of these parameters at once. Don't really need to worry about that. The last column in the table here is really the maximum allowable output for a range of given pitches for different rotation times. Okay, so say we have a protocol that calls for an effective mass of 280, and we've got a rotation time of half a second, and we've got a pitch of 0.8. On our table, this is where we are at. We can see that with our effective mass of 280, we are pretty significantly below the maximum, so we shouldn't run into any problems hitting the tube limits. Okay, but our total scan time is 20 seconds, and we want to cut that down to 15 seconds, have it be within a single breath hold. What can we do to reduce the scan time of this particular protocol? Well, one of the things we could do is increase the pitch. Go to a pitch of 1.1. Okay, this would bring our scan time down to 14.5 seconds, so we've hit our goal of having it be 15 seconds or less. But if we look at the table here, the maximum allowable output from this scanner is only 264. We can't get our 280 that we wanted, so this would not be acceptable. Okay, what if we just bumped the pitch a little bit, made it a little bit shorter, and went to a pitch of 1.0? Now our maximum allowable is 290, so we are within our limits with 280, not by much, but we can make it. But the scan time is 16 seconds, so we're close, but we just didn't quite hit it where we wanted to. What else could we try? Well, what if we reduce the rotation time to 0.33 seconds? If we look at the table and we say, okay, at a rotation time of 0.33 seconds, what's the largest pitch we could have for the shortest scan time and still be able to get our 280 effective mass? Well, the largest pitch we can have at that rotation time is 0.6, and when we work this out, this gives us a scan time of 17.6 seconds. So we still haven't hit our goal. Now, the one thing I want you to note on this slide is that there are no happy faces. Okay, there are going to be circumstances where you just can't get what you want. Everything's a compromise, everything's a trade-off. Okay, there are some other things that we could try. We could think about possibly using a wider detector configuration, maybe going to thicker slices, and then we could reduce the mass. Those are some of the things I'm going to talk about now. Okay, slice width. I like to think of slice width as being kind of the size of the bin that we're going to use to collect photons with. And the wider that bin, the more photons we can collect in that slice. Okay, so we know that slice width will affect the number of photons in it in any given slice because of the bin size. So it will affect noise and it will affect low contrast resolution. Well, what about dose? If you don't change anything else, dose is independent of slice width. However, there is a great temptation to increase the technique, to increase the mass, to increase the dose as we go to narrower and narrower slices. And let me just show you an example of what happens. Okay, we know that noise is inversely proportional to the square root of the number of photons. And we're going to start with a 5 millimeter slice here as our reference value. Okay, let's say we want to go to 2.5 millimeter slices. Okay, our noise goes up 141% compared to our 5 millimeter slices. And if we wanted to match the noise with the 2.5s, that of the 5s, we would have to increase our mass, increase our dose by 200%. Okay? As we go to thinner slices, 1.25s, now our noise is up 200%. If we wanted to match the noise of the 5s, we would need to increase it 400%. And finally, as we get to the thinnest slices, our noise is up 283%. If we wanted to match the noise of the 5s, we would have to increase our dose 800%. Okay, so with smaller image slices, we do get better Z resolution, which means less partial volume averaging, and I'm going to show you some examples of what that is in the next few slides. However, we do get this inherent increase in image noise, and there is this great temptation to try to compensate for that noise by increasing your mass as you go to thinner and thinner slices. Okay, partial voluming. This is a series of images from the ACR slice thickness phantom, and all this image is it's a series of bars, and it's at an angle to the beam. So the more bars you see, the greater your slice thickness. And I'm showing slice thicknesses ranging from 10 millimeters down to 1.25 millimeters. I've also included at the bottom some noise measurements, so you can see, yes, as we go to thinner and thinner slices, our noise increases. But the thing I want to point out with this is notice the brightness of these bars as we go from the thick slices to the thinnest slices. The brightness increases. The contrast is much greater for the 1.25s as it is for the 10s. This is because as we go to thinner and thinner slices, we are looking through less material that's in front of that object and behind it. So as we go to thinner slices, we are looking at more of a true representation of that object. And that's called partial voluming. When we have to look through a lot of material in front of and behind the object, we are partial voluming that object. So that's, through the phantom images, why thinner slices are attractive. Let me show you a clinical example. This is a 10 millimeter thick image, and what I want you to do as I click through and the slices get narrower and narrower I want you to look at the organ boundaries, and I also want you to pay attention to this area in the liver right here. Okay, here's our 10 millimeter images. We go to 5s, and I'll just click back and forth between this 10, 5. Things are tightening up already, you can see with the 5s. Here's the 2 millimeter images, and look at that spot where I had highlighted. I don't know how well you can see that out there, but there is a little spot there. It's possibly a cyst or some other object, and it is fairly high contrast, and it is very small, and it couldn't be seen, at least not by a physicist, at the 10 millimeter images or even at the 5s, but it's clearly obvious on our 2 millimeter images. What happens when we go to 1 millimeter? It becomes even clearer. The organ boundaries become a little sharper because we are not partial voluming them as much anymore. Let's go one more step to 0.6. And now you can see we're getting to a point where the image noise is really starting to overwhelm things. And you can imagine if we went a little bit thinner or hadn't used quite as many photons as this, we would lose that object again in the noise. Okay, so clearly the answer lies somewhere in between. Again, we need to target what we are doing to what we are trying to see. The next thing we're going to talk about is detector configuration. And detector configuration is ultimately going to determine how wide your collimation is, how wide your beam is, and what different combinations of slice thicknesses you have to choose from when you reconstruct things. Okay, with so many channels available today, 64, 128, and more, you can imagine that there are a tremendous number of options to choose from as far as different configurations and different total collimations. However, not all of these combinations are available under all circumstances. And actually, the vendors do a pretty good job of limiting the choices you have based on the protocols you've selected and what you're trying to image. Generally, narrower collimations mean less scatter, which gives us better low contrast resolution. However, we do get less coverage because we're covering less per rotation. And there is a potential for a decrease in dose efficiency as we go to the thinner collimations. And I want to show you an illustration of why that might be. What we're looking at here is a wide collimation compared to a narrow collimation, and this is by no means drawn to scale, but I want you to pay attention more to the areas down by the detectors here. Okay, with our radiation beams, I think we're all aware that the edges of our radiation beams are not completely well defined. That is, they taper off at the edges. They have fuzzy edges, if you will. Well, it turns out that this area, which is called the penumbra, this penumbral region isn't very useful for imaging. So what the vendors have to do, they have to overshoot the beam to project this penumbral region outside of the active detectors. Okay? Since that part of the beam is not being used to create image and contributes only to dose, that penumbral region is completely wasted. Okay, and what I'm going to do here is mask out the useful region of the beam. So now we're looking only at that penumbral region. We're seeing the wasted components of the radiation, which is projected out over the active detectors. So it's not used to create the image. It only contributes to dose. Well, if we consider that penumbral region, for the ranges that we're interested in, it doesn't really matter if the beam is very wide or very narrow. That penumbral region is about the same size regardless. So when we look at the narrower collimations, a larger portion of the narrower collimations is wasted radiation compared to the wider collimations. For example, if we wanted to match the coverage of the wide beam with the narrower beam, our illustration would look like this. So you can see that because of this, there is a potential for these narrower collimations to be much less dose efficient. Now, I understand that some progress has been made in trying to limit this So it might not currently be as bad as it used to be, but there is the potential for these narrower collimations to be less dose efficient. Okay, so we know detector configuration affects the total scan time because it can affect the total collimation, the total beam width. It can affect the noise and the low contrast resolution, and it also can affect the thinnest available recons, the thinnest recons that are possible after the acquisition. A few things to note here. We typically recommend using the thinnest channel widths for best image quality. This is also important if you're going to be doing any reformats where you would want very thin images. At least you will have those available. And it's also a way to avoid some artifacts. As I mentioned, some configurations are less dose efficient. The good news with this is that you can compare the relative effectiveness or efficiency using the CTDI vol values on the console. Okay, and this is true of everything that I've said and everything that I'm going to say. You can make these adjustments on the scanner without having a patient on the table and look to see how that CTDI vol changes. It will tell you the total scan time. It will tell you what the CTDI vol is. It'll tell you the effective mass. It tells you all of that, and you can just make the changes at the console kind of after hours at your leisure and see what effect it has on the doses. See if there is a sweet spot in any particular configuration. Very, very easy to do. The next thing is the kilovoltage or the kV. We know that the linear attenuation coefficients, the things that we measure in CT, have an energy dependence. And so if we change the energy content of our beam by changing the kV, we will affect the contrast resolution. We also know that there's an energy dependence on the dose, and so changing the kV will affect the dose as well. A few things to be aware of, and this, I believe, is a whole separate section later on in the summit, so I'm not going to go into any of this in a lot of detail, but just to note it here, if you do change your KVs, you will need to change your MA. Okay, there's a different relationship with that, and if you use a different KV, you will need to use a different mass, a different technique. Any bolus tracking thresholds that you might be using will be different when you change KVs. The Hounsfield units are different, the CT numbers are different, so you will have to change any bolus tracking thresholds with different KVs. And finally, make sure that your scanner is calibrated at the kV that you're using. It's not too uncommon for sites that don't use, especially some of the lower kVs, 80 kV, 100 kV, that they don't have their scanner calibrated at those kVs. Well, if you decide you want to explore using different kVs, make sure that your scanner is calibrated at those kVs. Here's a few examples. We got an image at 140 kV, and the image on the right is at 80 kV. And even though the image on the right at 80 kV uses a much higher mass, you can see that it looks a little bit more noisy than the one at 140. And this is because of the relationship of tube output with kV, and also because the photons aren't as penetrating at the lower energies. However, I hope you can appreciate that the image on the right at 80 kV has much superior contrast. The contrast is much better with that image. And again, this will be a whole separate session later on in the summit. Lastly, I want to talk about the reconstruction algorithm. The recon algorithms really affect anything to do with noise and spatial resolution. Okay, these can have very obvious to very subtle effects on the images, and so you really need to get the consensus of the radiologists on this to determine what is the most appropriate algorithm or kernel to use on any given exam. The good news with this is that exploring the different algorithms is really painless and free. If you have the raw data, you can reprocess it over and over, each time using a different algorithm. You can prepare multiple series using different reconstruction algorithms, have the radiologists sit down, review these, determine which ones they're most comfortable with, which ones they're most confident with. So again, it's a very easy thing to do. You don't have to rescan the patient. You can work with the raw data and just reprocess these. I kind of think of the reconstruction algorithms as being like an equalizer on an audio system. You have adjustment to adjust the various frequencies. You can make the sound smoother or more crisp. You don't have to re-record the music to do that. You just replay it and make the adjustments, see what you like best. And here's just some simple examples of the effect of the reconstruction algorithm on image noise. You can see the top one is fairly smooth down to the one in the lower right-hand corner, which is essentially unusable. And then here's the effect on frequency. We have very sharp images up in the upper left-hand corner down to unusably smooth images in the lower right-hand corner. So in conclusion then, there's not always a perfect answer. As a matter of fact, there's hardly ever a perfect answer. What we shoot for is to determine the best parameters for standard conditions. And I believe there's going to be lots of ideas and thoughts on this in other sessions. It's also a good idea to have some guidelines prepared for some atypical conditions. And I have written down here large patients. That should probably be very large patients, because large patients really aren't atypical. But very large patients, metal implants, these kind of things that you don't see too often, but eventually one of them is going to end up at your scanner. Also, there will inevitably be moments where somebody has to make a decision on the fly, where something presents itself and you just can't do it with what you have. And my advice for this is know your scanner, know the functions, know the capabilities, know what it can do. And this isn't advice just for the physicists. This is really for the technologists, the physicists, and the radiologists. Everybody has a stake in this. Everybody has their own unique perspectives, experience, and expertise, and everybody can contribute to making the scanner work as best as it possibly can. Thank you.
Wow, the timer just went off. We have 3 minutes. Way to go, Jim. Perfect timing. You know, please, I invite you to come up. But while people are coming up, how long does it take you to do all these kind of things in terms of your optimization? You obviously have a unique advantage that you're at an institution and that you get to be able to do those things after hours. How long does it take you, for instance, to optimize a particular exam?
Well, it depends. A big part of this is determining what we need, and that's probably the most time-consuming part. And I am going to talk a little bit about that tomorrow when I talk about protocols, but getting the right people in the room, getting the right information, getting the consensus of the radiologists, all of that is very time-consuming. Once we know what we need to do, we can get there pretty fast, a few evenings with some phantom images. And then you want to start trialing things kind of on a case-by-case basis, having the radiologist review it in between to make sure you're on the right track at least.
Great. Another question from the audience.
Hi. My question would be, in the beginning you kind of were speaking mostly about helical scans, but then you went on to talk about the dose issues with these thinner slices, yet, at least in my experience with a number of the MGCT scanners, you have a situation where the collimation is fixed. So, for instance, with the GEVCT, it's like 0.625, and then they use, it's a 40 millimeter beam width. So, basically, the slice thickness is not really, quote-unquote, slice thickness in an environment where you're doing a helical scan. You're really looking at, what detectors am I using in this 40 millimeter width? And so you can have a 0.625 slice or a 1.25 slice or whatever slice you want, and there's no dose consequence in a helical scan. Is that true or not?
Right. That depends on the total collimation there. When you're talking about from the 20 centimeter to the 40 centimeter, not a big deal. What I was thinking is like the 1x2
right,
mode,
and that's true in an axial environment, but in a helical environment, I mean, we kind of need to be talking about beam width, not necessarily just collimation. Wouldn't that be true?
Right, beam width being equivalent to collimation.
Whatever the beam width is being, whatever you come up with for that beam width in helical scanning is what's going to be. That's where your penumbra is going to be apparent and things like that. So the slides that you spoke about, I just wanted to make sure that we're clear that that's about axial scanning, not helical scanning, because in helical scanning it's different.
Helical as well, because that penumbral region can't be used. So if that has
yes,
to be
but the penumbra is on the edge of that beam width, so it's on the edge of that 40 millimeter beam width, not a 0.625 millimeter beam width.
Right. The thinner collimations is where that gets really exaggerated. And the point about the different collimation choices, with the case of the VCT being 20 or 40, I actually had a slide that I didn't show with one of the older GEs, where it showed all of these different permutations that you had a choice for collimation. So I think that was nice that they are limiting the choices like that for some of the main exams, so the user doesn't have to worry, do I use this collimation or that collimation or this detector?
And just one other comment is what's your opinion, because I really would like to see the AAPM or the ACR get to a point where we have some kind of maybe an overburdenment that's on top of the ACR Phantom so that we can actually use the dose reduction software. Right now we have to turn off all of that dose reduction software, and we can't really tell, is this an appropriate abdominal helical scan that we have, because we kind of fool it into doing this thing without any dose reduction software like CareDose 4D or Smart MA, Auto MA.
And that's a great issue and a great question. That's something we struggle with when we're trying to look at the dose modulation, and we've gone to some great lengths with super flab slabs and trying to build up different shaped phantoms. So.
I'm getting the axe from my facilitator here, so let's move on to the next talk.